imbalanced vegetarian diets where there is insufficient amounts of iron intake. And for neonates, we have when the main source of milk is from cow's milk. So for decreased absorption, we have two forms of dietary iron, the heme and the non-heme iron. So in which iron is complexed as ferrous iron or the Fe2+, and it is soluble and easily digested or absorbed by the body. The non-heme or the ferric iron is much less well absorbed, and its absorption is smartly improved by the presence of gastric acid, which assists the absorption of iron by the body. Therefore, gastric acid usually assists by dissociating the iron salts due to its high pH, therefore increasing the solubility of the non-heme iron for it to be absorbed by the body. So therefore, in cases of autoimmune gastritis and Helicobacter pylori infection, where there will be hypochlorhydria or decreased gastric acid secretion, there would be a problem in iron absorption because, as I've said earlier, gastric acid is an important factor for the non-heme iron absorption, as it requires acidic pH, and gastric acid aids in the liberation of iron from the food through digestion and facilitates its conversion from ferric form to ferrous form. So an additional info is that vitamin C also facilitates the dietary iron absorption with the same manner as the gastric acid. So another diseases that affects absorption of iron is celiac disease. This is due to the iron absorption is mainly happening in the proximal duodenum. But this specific part of the intestine is the specific area that is destroyed by celiac disease. Therefore, impeding in the absorption of iron. So another disease is the inflammatory bowel disease, under which listed is the Crohn's disease. It causes an inflammation of the digestive tract, which could lead to it causes inflammation, which could further lead to destruction. Therefore, again, impeding in the absorption of iron. And last is the iron refractory iron deficiency anemia, which is a hereditary disease. It is characterized by a mutation of the TMPRSS6 gene, which is the gene responsible for coding the protein matrictase 2. So this protein is the one that controls hepsidine levels, and hepsidine is a key regulator of iron balance in the body. So if there is a high level of hepsidine in the blood, it will decrease the absorption of iron from the diet. Therefore, it will lower the iron levels in the bloodstream, leading to anemia. So for increased demand, we have pregnancy, growth years, especially in adolescent stages, and periods of increased blood regeneration, especially, for example, after a blood transfusion, bloodletting, or after you donate blood. So there will be an increase in the blood regeneration. So last cause of iron deficiency anemia is hemolysis increased loss, which is further divided into two, hemolysis and hemorrhage. So intravascular hemolysis, and for hemorrhage, we have menorrhagia, gastrointestinal bleeding, acute blood loss, chronic nosebleeds, and urinary losses. So for pathogenesis and pathophysiology, we have this picture, which I will discuss later. So these are the changes in laboratory parameters as the iron deficiency progresses before it would be defined as iron deficiency anemia. So for clinical manifestations, we have extreme fatigue, weakness, pale skin, chest pains, tachycardia, dyspnea, lightheadedness, cold extremities, glossitis, brittle nails, pica or craving for non-nutritive substances, and poor appetite. For diagnosis, we have the CBC and RBC indices, all of which are decreased except the RDW. This means that there would be variation in the size of RBCs, and the peripheral blood smear of this sample would show an anisocytosis. So for iron studies, we have serum ferritin, serum iron, transferrin saturation, which are all decreased, and the TIBC increased, while the bone marrow iron will have no stainable iron. And for special tests, we have the free erythrocyte protoporphyrin or zinc protoporphyrin, which will be increased, and the soluble transferrin receptor, which will also be increased. So for treatment, we have the best approach for treatment of iron deficiency anemia is to treat the underlying cause. So the usual treatments are the oral supplements, which is the first line of treatment for iron deficiency anemia, and usually given to patients with decreased intake or increased need. We also have parenteral iron dextrans, which is usually given for patients with impaired absorption, and blood transfusion for those patients with increased loss. So these are my reference. I will move on to my next topic, the journal article. So from the article, oh,
So you can reserve your questions
uh,
after the presentation. Okay.
the Amesis, Raimondi, Eli, Mota, and Mota, entitled Acquired Refractory Iron Deficiency Anemia, published in Italy on the 1st of May 2001 on the Mediterranean Journal of Hematology and Infectious Disease. So, the bulk of my report will circle around the underlying conditions of refractory anemias together with the specific diagnostic approaches and treatment. So for introduction, again, iron deficiency anemia is simply defined as anemia of low iron, and refractory means no response to treatment. So together, iron refractory anemia is an anemia without hematologic response after 4 to 6 weeks of treatment using oral iron, which I said earlier is the first line of treatment for iron deficiency anemia. So, how do we say that a response is sufficient? It would be an increase in of more than 1 gram per deciliter in hemoglobin concentration. So, we all know that iron deficiency doesn't necessarily mean anemia. For an iron deficiency to be called anemia, it must go through three phases of iron depletion. So we have again the four laboratory parameters that differentiates the three phases of iron depletion. So hemoglobin, we have serum iron, total iron binding capacity, which is a good and direct measure of transferrin. And the transferrin is the main transport protein of iron. And lastly, the serum ferritin, which is the main protein that stores iron. So for the first phase of iron depletion, we have storage iron depletion, which is manifested by a decrease in the ferritin levels. So next would be the transport iron depletion, which would show an increase in Tibc, therefore an increase in transferrin. So an increase in transferrin is triggered by a decrease in iron levels in the blood. Lastly, the last phase, which is the functional iron depletion, manifested by decrease in hemoglobin content of the RBCs. At this point, the iron deficiency is now called iron deficiency anemia. So the first choice of treatment for iron deficiency anemia is always oral iron therapy. Iron absorption through oral therapy is limited to 1 to 2 milligrams daily. So the protein responsible for iron absorption is hepsidine, and it influences iron absorption through attachment to ferroportins. So when a hepsidine attached to the ferroportins, it would usually lead to their degradation. So ferroportins are proteins, transmembrane proteins that are usually found in macrophages and enterocytes. The main function of ferroportin is to transport iron from the two cells going outside into the blood plasma. So, macrophages are usually used for iron recycling from senescent RBCs, contributing to 20 to 25 milligram of iron daily, while enterocytes or are intestinal cells that absorbs iron from the diet, contributing to the 1 to 2 milligram daily I said earlier. So that's why iron absorption through diet is limited to 1 to 2 milligrams daily only. So to reiterate, an increase in hepsidine will cause a decrease in surface ferroportins, leading to decreased iron absorption of enterocytes and recycling of iron by the macrophages, which would ultimately lead to decrease in plasma iron levels. So there are several underlying conditions that contributes to an iron deficiency anemia not respond to treatment. That's why they would become iron refractory anemia. So these are autoimmune atrophic gastritis, Helicobacter pylori, celiac disease, surgical procedures, occult blood losses, drug-related iron refractory anemia, self-induced bleeding, and iron refractory anemia and hepsidine dysregulation. So first is the autoimmune atrophic gastritis. So this is a kind of chronic atrophic gastritis together with the Helicobacter pylori. So it is characterized by loss of gastric glands and replaced by pseudopyloric or intestinal metaplasia or fibrosis. So it is caused by antiparietal cell antibodies, therefore it being an autoimmune disorder. This would result in an impairment in gastric acid secretion, which I said earlier is important for the reduction, solubilization, and absorption of iron. So, chronic atrophic gastritis have two types, this being the type A or the autoimmune, and the type B is the due to environmental factors, which is Helicobacter pylori. So Helicobacter pylori is the other kind of chronic atrophic gastritis, which presents the same manifestations with autoimmune atrophic gastritis. However, occult blood loss is included as a cause of iron deficiency anemia due to erosive gastritis and peptic ulcers. So, uh, H. pylori infection is also attributed to decreased ascorbic acid in the gastric juice, which I've mentioned earlier, needed for the iron reduction. So this would lead to decreased iron absorption and utilization. For the third disease, we have celiac disease. So this is an autoimmune disease against gluten, carrying the HLA-DQ2 and DQ8 genes. So in celiac disease, there is an inflammation of the gastrointestinal tracts, which would ultimately lead to iron malabsorption. So for surgical procedures, we have one example, the bariatric surgery. Um, so the bariatric surgery are the surgeries that's goal is mainly for weight loss and obesity management. So for example, we have the gastric bypass. As you can see in the picture. So simply, gastric bypass is where a small portion of the stomach is immediately connected to the small intestine, resulting in a smaller stomach. And we have the sleeve gastrectomy, which is the removal of a portion of the stomach. Again, this would lead to a smaller stomach. So, with these bariatric procedures, iron deficiency anemia may present pre-operative and post-operative. So, pre-operative, um, obesity-induced systemic inflammation may increase hepsidine levels. So, hepsidine, again, being the main regulator protein for iron levels in the blood. And the higher blood volume due to higher body mass may make the iron intakes of the person so insufficient to support the body's iron needs. So in the other hand, after the operation, iron refractory anemia may present through reduced appetite, in turn reduced nutrient intake, alteration in the gastrointestinal anatomy and physiology, resulting in reduced area for iron absorption and gastric acid secretion. So, yeah. So another kind of surgical procedure that may lead to iron refractory anemia is the surgery for ulcerative colitis, which involves partial or complete removal of colon. So one of the possible complications of this surgery is the development of pouchitis. So pouchitis is usually associated with mucosal bleeding and impaired iron absorption. And another surgery is the ileal urostomy, which is the use of ileum as a passage for urine after bladder removal. So a recent study shows that children and adolescents that underwent ileal urostomy have reduced serum iron and increased TIBC with unknown etiology. So for occult blood losses, um, or indistinguishable blood losses that usually results to iron refractory anemia. An example would be diaphragmatic hernia and esophagitis. So wherein there is a hole in the diaphragm leading to the stomach, the esophagus, sometimes the liver being squished on the above the diaphragm due to them passing through the hole in the diaphragm. So it usually results to what we call the Cameron lesions, which are linear gastric ulcers or erosions in the mucosal folds of the diaphragmatic impression. So due to these lesions, it may induce gastric bleeding. So hernia-related hernia-related iron deficiency anemia due to the mechanical trauma and erosions or the gastroesophageal acid reflux will further contribute to the exaggeration of the formation of these lesions. And also under occult blood losses are small bowel vascular lesions in which majority of GI bleeding is of unknown origin, despite a comprehensive gastrointestinal evaluation. The American College of Gastroenterology guidelines lists down the most common causes according to the age groups, being 40 being the standard age or the reference range age. For those patients above 40, we have the Dieu-Lafoy's lesions, which are large lesions of the stomach wall that erodes and bleeds. We have neoplasia, which are uncontrollable growth of cells and tissues. It can also be it is also listed on the usual causes of small bowel vascular lesions for those patients below 40 years old. So unique to the patients above 40 years old are an angioectasia, which is a collection of abnormal blood vessels composed of thin capillaries without elastic membrane. So therefore, they are very susceptible to breakage leading to bleeding, and non-steroidal uh, drugs which uh, which could induce ulcer that interferes with the stomach's ability to protect itself from gastric acids by interfering with the mucosal lining of the stomach. So for the ages below 40 years old, we have the Megals Diverticulum, which is the bulging of the small intestine is usually a leftover from the umbilical cord, and the polyposis syndromes, which are simply polyps in the digestive tracts. So this um, are usually the common causes of the small bowel vascular lesions. Lastly, for the occult blood losses, we have intestinal parasitic infections. The most common is the hookworm, Entamoeba histolytica, and Trichuris trichiura. So for hookworm infection, they evoke occult blood losses through mucosal damage of the colon and leading to endogenous loss of iron. While the Entamoeba histolytica and Trichuris trichiura causes bleeding and dysentery by invading the mucosa of large intestine. So for drug-related iron refractory anemia, we have the use of protein pump inhibitors. So protein pump inhibitors are drugs that are usually given for treatment of GERD and for peptic ulcers. So they usually induce hypochlorhydria or achlorhydria, which is decrease in or the loss of secretion of the gastric acid, which is important for iron absorption. So continuous use of this drug for longer than a year may increase the risk for iron deficiency anemia due to malabsorption of iron. So even if they are given oral iron treatment, which is the first line of treatment for iron deficiency anemia, they would yield suboptimal response. So trigger warning for the next slide, we have topics of self-harm, so which could trigger. So kindly call my attention if anyone feel any discomfort, and I'll immediately move on to the next topic. Thank you. So cause or underlying cause, we have the self-induced bleeding, which is called Lassini-Differential syndrome. It is a rare psychiatric disease characterized by repeated episodes of self-induced bleeding. So it mainly affects women, and these patients usually appear as very cooperative, and they usually submit to their procedures for their diagnosis, and they often improve with therapy except on instances of relapse, making the treatment challenging. So despite their debilitation, they continue to function their professional and social duties. Okay. For our last underlying condition, we have the iron refractory anemia and hepcidine dysregulation. So all of the five that is listed below this subcategory are which are results in high hepcidine levels. So yes. So first is the iron refractory iron deficiency anemia, which is a mutation in the TMPRSS6 gene, as I've said earlier. So this is a hereditary condition, and it presents microcytic anemia. So next is the anemia of chronic disease, which is also called the anemia of inflammation. So it is characterized by an increase in interleukin 6 resulting in activation of STAT3 mediated hepcidin expression. So it usually presents with a normochromic and normocytic with reduced reticulocyte count. Third is the inflammatory bowel diseases, where anemia is the most common extraintestinal complication, which is present in more than 70% of the patients with inflammatory bowel diseases. So, the cause of iron refractory anemia in inflammatory bowel diseases is through the chronic blood loss in the gastrointestinal tract, usual reduced iron intake, and iron absorption. So, for chronic kidney disease, hepcidine is cleared by the kidneys, where it is reabsorbed and degraded. So, in cases of chronic kidney disease where there is an inflammation of the kidneys, there is decreased clearance of hepcidine, resulting to increased hepcidine levels in the body. So, hemodialysis could also contribute to the blood loss due to the residual blood left in the dialysis equipment, and for the anticoagulation that is used during the dialysis treatment, and the blood loss during the iatrogenic blood loss that is brought about by frequent laboratory testing. So, frequent blood drawing from the patient. So lastly, we have hepsidine adenomas, which presents the RBCs as microcytic and hypochromic. So it is caused by treatment for patients affected with a type 1A glycogen storage disease. So this disease is a rare recessive disorder due to deficiency of the glucose 6 phosphatase. So this enzyme is a uh, catalytic enzyme that is involved in the glycogenolysis and gluconeogenesis. So the treatment for this disorder is focused on prolonging the survival of the patients. But the one of the side effect of this treatment is liver adenomas. So it has been observed that there is a correction of iron refractory anemia after the removal of these adenomas, which leads to studies that showed inappropriately high expression of hepcidin mRNA in the adenomas tissue, while while with adenom when compared to a normal liver tissue where there is a normal hepcidin suppression if there is already low iron levels in the blood. So for the diagnostic approach, the researchers provided a flowchart on how to properly approach iron deficiency anemia and unexplained iron refractory deficiency anemia. So let's tackle each of these sections in detail. First is the upon the diagnosis of iron deficiency anemia, a detailed medical history must be obtained in order to narrow down the possible causes of IDA. So, surgical history might be able to discern bariatric surgery as the cause of IDA. We have psychiatric records that might show last knee differential syndrome as the cause. For medications, it might reveal the use of protein pump inhibitors that causes drug-induced iron refractory anemia. Medical history might say that there is an ongoing chronic kidney disease on the patient, and um, it might also reveal hereditary disorders like the iron refractory iron deficiency anemia if a detailed medical history is obtained. So this is after this, if the patient is the underlying cause is not yet determined after this phase, it is the patient is um, classified into two categories. So the pre-menopausal women on the left side, and we have the for on the right side we have the post-menopausal women and men. So for the pre-menopausal women, we have it is usually it is subdivided into this because premenopausal women usually the usual case of in iron deficiency anemia in this population is due to increased physiological need like pregnancy or in cases of heavy menstruation. So in this case, if they have these conditions like pregnancy or increased menstruation, the usual treatment is oral iron therapy. So, however, if the patient does not respond to oral treatment, it would now be considered iron refractory anemia. So, on the other side, we have if the patient is a man or a postmenopausal woman, iron deficiency anemia due to increased physiological need is ruled out. Therefore, sets of tests like colonoscopy, endoscopy, GI biopsies are the next step to rule in underlying causes such as celiac disease, autoimmune atrophic gastritis, Helicobacter pylori infection, and inflammatory bowel diseases. So, however, if we still come up with negative on the above tests, the etiology is considered unexplained refractory iron deficiency anemia. So, supplemental tests can be done in order to further rule in underlying causes such as parasitic infection. So, the capsule enteroscopy is used for detection of small bowel lesions and high hepsidine conditions such as in hepsidine adenomas, chronic kidney disease, and the iron refractory iron deficiency anemia. For specific diagnostic approaches, we have for autoimmune atrophic gastritis, we have cobalamin testing, serum gastrin testing, and antiparietal cell antibody testing. So for Helicobacter pylori, we have Helicobacter pylori fecal antigen, urease breath test only if the patient is not under or using protein pump inhibitor drugs, and endoscopy with biopsy is optional due to its invasiveness. So for celiac disease, we have the tissue transglutaminase, IgA antibodies, duodenal biopsy, and the HLA screening for DQ2 or DQ8 gene. And lastly, for the iron refractory iron deficiency anemia, it is usually detected through the sequencing of the TMPRSS6 gene. So for treatment, oral iron therapy is the first line treatment of iron deficiency anemia. So for autoimmune atrophic gastritis, oral iron is effective for patients with mild anemia. However, adjunct vitamin D and B12 therapy is advised. So for Helicobacter pylori infections, oral iron supplementation remains an effective first-line treatment, but it yields slower treatment and recovery. Therefore, the infection should be first eradicated so that the response would be more rapid than just iron therapy. For celiac disease, we have sucrosomal iron and iron compound based on alginic acid and ferrous bisglycinate, uh, which are proven effective for instead of just oral iron, the ferrous sulfate form. So for patients with IDA due to bariatric surgery, according to the American Society for Metabolic and Bariatric Surgery, oral iron therapy is the first choice of treatment. It should be divided into doses and should be given separately from calcium supplements and acid reducing medications. If the patient would still be unresponsive to this treatment, IV iron therapy should be administered. For iron refractory iron deficiency anemia, it is shown that IV iron leads to slow and partial correction because hemoglobin of IRIDA patients would rarely normalize with the microcytosis still persisting. However, IV iron therapy is preferred over oral iron because ferritin levels or iron storage would normalize or even increase after IV iron infusion. So for patients with chronic kidney disease, oral iron is recommended only in patients that are not receiving erythropoietic stimulating agents and not undergoing hemodialysis. So, if the patients undergo hemodialysis or are receiving erythropoietic stimulating agents, they should be given intravenous iron instead. So for inflammatory bowel disease, IV iron is the first line treatment. However, if the anemia that that manifests is only mild anemia, oral iron should suffice. So, in conclusion, we have iron deficiency anemia is a highly prevalent disorder affecting all ages but is still understudied. So, we have to delve further into the identification, diagnosis, specific workups, and treatments for this iron deficiency anemia. Again, this is my reference journal for this report, and thank you very much po.
Okay. So can we have a 5 minute break before we have the question and answer?
Okay, ma'am. Thank you po.
We will resume 9:20. All right, so it's already 9:20, so we can begin with the question and answer. So, Jim, now who wants to give the first question to Sir Jim? Sir Peter?
Yes, ma'am. Sir Jem, I have a question. Based on your report, can you explain what is the importance of hepcidin in iron absorption?
Yes, sir. Thank you for that question. So, hepcidine is the protein that is the main regulator of iron in the blood. So, in order to regulate the iron levels in the blood, it employs the help of ferroportins, and ferroportins are the pumps of iron storing cells such as macrophages and enterocytes in order for the iron from the enterocytes and the macrophages to go out from the cell outside into the blood cell plasma. So to regulate this flow of iron from the cell, from the enterocyte and macrophages to the blood plasma, the hepcidin would bind to the ferroportin and destroy it, therefore limiting the possible pathways of or blocking or yes limiting or blocking the possible pathways of iron from these cells outside into the blood plasma. So therefore, an increase in hepcidin would mean a increase in the ferroportin degradation, which would lead to decreased flow of iron from these cells into the blood plasma, resulting in lower iron levels in the blood. So that's how hepcidin regulates the iron balance of the body.
Okay, Sir Jem, thank you.
Thank you, sir.
Sir Jem, if we're going to simplify it, what's the relationship between hepcidin and plasma iron level?
They have indirectly proportional relationship because increased in hepcidin would mean decreased level of iron in the blood po.
What kind of mechanism happens whenever the hepcidin becomes low and then the plasma iron becomes high? So, what sort of mechanism is involved?
OMG. I don't know if my answer.
Is there some kind of is there a competitive inhibition? Is it a feedback inhibition? If you could
Oh,
probably look for like a simplified illustration or drawing of the hepcidin molecule showing how it interacts with the ferroportin that you just mentioned so that we will understand how iron becomes inhibited by the hepcidin because you mentioned they are inversely proportional, right?
yes, ma'am.
Okay. Can you please look up for a diagrammatic representation of the hepcidin acting upon the iron so that we will further understand how crucial hepcidin is in maintaining the stable iron levels.
Yes, ma'am, will do po.
Um, anong klaseng feedback? What kind of feedback mechanism is involved in the reaction between hepcidin and the iron? Okay. Because
Yes,
hepcidin
ma'am.
also plays a role in inflammation, right? So I think you also mentioned in the previous slides how hepcidin becomes elucidated during inflammatory conditions. Okay.
Yeah.
So even if the topic is about IDA, okay, in some situations, the hypochromic microcytic anemia would also become apparent during ACI, or anemia of chronic inflammation. So they share the same blood morphology, which is microcytic and hypochromic. Although if we're going to differentiate them, okay, so the in ACI, okay, the iron is relatively normal compared with the IDA, okay, which of course, as the name implies, would have low levels of iron. Okay, so we will expect the diagram next week, Sir Jim.
Yes, ma'am. Thank you
Okay.
po.
Okay. You mentioned about iron deficiency anemia remaining as a highly prevalent disorder or condition, right? What do
Yes
you
po.
think? What do you think? Why do you think it still remains to be a prevalent disorder despite a lot of studies, a lot of knowledge about IDA and do you think what do you think contributes to this prevalence?
Ma'am, based on my readings and my own beliefs, I think that the reason why it still remains as a prevalent disorder or condition is because the underlying causes of iron deficiency anemia remains much of it is of usually unknown etiology. That's why even if they discovered the cause, however, uh, they could not find a they could not find the best solution for treating the iron deficiency caused by the said underlying causes. So that and sometimes it I've also read that some iron deficiency anemia remains undiagnosed because of it remains mild. Therefore, the patient does not feel anything, or like they just feel mild dizziness or mild headaches. Therefore, they dismiss it as something not serious. But in reality, they already have or developing iron deficiency anemia. So, I think that's also another factor to consider why iron deficiency anemia remains to be one of the prevalent conditions. Thank you po.
Yes, I would have to agree with that. In probably in most cases of IDA, so there are no further testing being done on the patient. So probably the yeah, so the underlying condition or cause. So it happens that the IDA might only become secondary. So it could only serve as a complication, but not the main problem.
Yes, ma'am.
The IDA remains underdiagnosed and undetected. Okay. Now you shared a picture about the different stages of anemia, right? So you have
Yes.
stage one, stage two, and then stage three. So the stage three actually that's the frank anemia already, wherein all
Yes,
of
ma'am.
the signs and symptoms, okay, are already present in the patient. Okay, so if you look at the picture, okay, can you share it again, Sir Jem?
Sige, ma'am. Wait.
The
Okay,
different
ma'am.
stages. Okay.
Just a second po. This one, ma'am.
Yes, okay. So you have the three stages of anemia. Okay. So now the three stages, okay, so show the how iron becomes gradually depleted, okay, depending on the stage.
Yes, ma'am.
So, do you think this three stages also uh, contribute to the underdiagnosis of IDA? What is present in stage one? Is the
Only,
patient
ma'am,
symptomatic or not symptomatic?
mm, ma'am, according to what I've read, the most of the symptoms, or like most of the alarming symptoms, persists or presents themselves when the patient is already on the stage 3. However, I believe that, or I think, whenever there is an abnormality that's going on in our body, there would be, little signs or little symptoms that would present, but because of we sometimes dismiss it as something that would easily go away, or just a simple, like for example, headache or dizziness, then we are not really alarmed by it. But however, during the stage 3, where there are many abnormalities already, like hemoglobin are already decreased or even markedly decreased, therefore the symptoms would be on a much higher intensity. Therefore, that's when that will be the time that the patient would usually consult a doctor, and it would be discovered that the patient already this already um, already progressed into iron deficiency anemia. So I think they have factors, but yes.
It appears to be already in the late stage. That's the
Yes.
time that the patient will seek consult. So that's why it remains undetected or undiagnosed or underdiagnosed. Yes, Sir Alex, you're asking something.
Uh, Sir Jam, you mentioned earlier in your report that there are some anisocytosis in the peripheral smear of iron deficiency anemia, and I'm just wondering if you have a picture of the peripheral blood smear, or what do the red blood cells look like po? Yeah,
Uh,
thank you po.
Thank you, Sir Alex. But I'm so sorry to disappoint, but I don't have a picture ready for the the picture of an anisocytosis in iron deficiency anemia.
You can present it next week, Sir Jem. You
Yes,
can
ma'am. I
share the
will.
picture next week.
Yes po. I'll just add it on my presentation next week. Thank you, Sir Alex.
Now, another question. What is meant by refractory?
Ma'am, it is the no response to treatment, or unsatisfactory response to treatment.
So if therapy has been administered already, and yet the patient does not improve even after therapy, so that is now the term refractory, Sir Jem.
Actually, ma'am, the treatment that is it is specific, highly specific, that the treatment stated in this definition of iron refractory anemia is about the oral treatment only. Therefore, other treatment like the IV iron therapy might work for the iron refractory anemia.
But you mentioned many times the word refractory. So
Yes,
you have another term, drug induced. So
yes, ma'am.
can we be clarified on on the meaning of just the term refractory? Only the term
If
or only the word refractory?
if only the word refractory, ma'am, it means no response to treatment, or yun nga, or the insufficient response to treatment po.
All right. Another question is, so were you able to describe the high risk population for IDA?
Yes, ma'am. It the high risk population for IDA includes premenopausal women, elderly males, infant, pregnant women po.
Mostly females.
Yes, ma'am.
Another clarification. Can you do you have any more information about the iron studies? Okay, so earlier you showed to us the relationship between the levels of this iron. I think you have a slide showing the iron studies. So can you differentiate ferritin from serum iron from TIBC, transferrin saturation?
Okay, ma'am. So, seroferritin is the main protein for iron storage. So, it is it is usually measured for the iron storage of the body. In the serum iron, it is the free iron that is in the circulation of the blood or in the serum. And PIBC, or the total iron binding capacity, is indirect measure of transferrin. So transferrin is the main transport protein for iron, and transferrin saturation, that is the it is usually computed, that is serum iron over the TIBC times 100, because it is usually expressed as a percentage. And bone marrow iron, it is done using staining. So if there are no iron found in the bone marrow, uh, there would be no stains that would be observed in this test.
Okay. Can you explain to us why the TIBC increases and transferrin saturation decreases?
Um, because the TIBC is it is usually computed as the UIBC, or the unsaturated iron binding capacity, or the transferrin uh, without iron, plus the serum iron. Therefore, if there is a decrease in TIBC, it means that there is low iron in the blood. So, whereas the transferrin saturation, it is expressed as serum iron divided by the TIBC. So, if there is a there is a decreased value of the transferrin saturation, there would be it means that there is a low iron compared to the total iron binding capacity of the said patient po.
Um, Please include also in your presentation next week the descriptions or definitions of these different forms of iron. Okay, and then for the TIBC, what binds to the iron? Okay, so that will be more so you will understand, okay? So the significance of all these
Okay
studies.
po, ma'am.
Uh Somebody's raising his hand. I think I saw it earlier. Taas ng kamay.
Opo, ma'am. Dito ba?
Okay, Sir Kenneth. Yes.
Sir Jem, since Aaron mentioned iron studies are mentioned in your report, what is the reference range for iron or serum iron, and is there a critical value or level by which intervention is needed?
Okay, sir. Thank you for that question. I'll just include it in my next presentation so that it would be visualized po. Thank you.
So is it um with the follow-up question to that, would there be a difference between the reference ranges among males, females? Okay, so please include also.
Yes, ma'am. Will do po.
Next question is what is the significance again of the reduced iron in terms of absorption? Reduced you mentioned about the ferrous and the ferric.
Ma'am, I'm sorry. I think my connection got slow. So I haven't heard the entire question po. Sorry.
So I'm asking about the iron. So you mentioned about the ferrous iron, and then you have the ferric. So which
Yes
one
po.
is reduced form of the iron?
Yes, ma'am. So the difference is that the heme iron is usually it is soluble, therefore it is well received by the body, well absorbed by the intestinal cells, while the non-heme or the ferric iron is less well absorbed. Therefore, there is a need for it to be reduced by the by acids such as gastric acids and the vitamin C, which is an ascorbic acid, there, so that it could be converted or reduced into ferrous, so that it would be absorbed better by the body.
So what is the how will you relate this information in terms of oxygenation?
Um,
And it that in the signs and symptoms that you shared earlier, so one of the signs and symptoms would be pallor, and then you have dyspnea. So if the patient presents with dyspnea, so probably there is some kind of compensation going on due to lack of oxygen. So kindly clarify the role of the reduced form of the iron on oxygenation level.
okay, ma'am. Thank you po.
Because you mentioned about the heme iron, which is more soluble, well absorbed, right?
Yes,
And you
ma'am.
know that hemoglobin functions for
Yes,
oxygenation,
ma'am.
right? Tissue
Yes, ma'am.
oxygenation. So there must be a connection there that will explain the significance of the ferrous iron and oxygenation level. Okay, Sir Jen.
Ma'am, question. Is this like the it's this in connection with the blood pH, or like am I in the wrong direction there?
Um, Somewhat related, but we also want to focus on the if you're familiar with hemoglobin oxygen affinity and saturation curve,
Okay.
if you still
Okay.
remember. Okay, so we are trying to find the connection. If there's something wrong with the iron, or if the iron is not in the ideal physiologic state, what would happen to
Okay,
oxygenation?
ma'am.
Okay.
Thank you very much
And
po.
of course, in IDA, if there is less absorption, okay, so that's a problem also, right? Okay.
Yes,
So we just
ma'am.
want to find the connection, okay? Sir, you're saying, ma'am, Sir Peter, you have a comment?
You're mentioning ma'am about the hemoglobin dissociation curve, tama po ba? In relation
Yes,
to the
oo. We're trying to find the connection, oo. Titingnan natin kasi everything is connected. Diba? So lahat yan magkakakonekta. Why is it that the patient presents with pallor? It has something to do with the oxygen supply, di ba? If a person appears to be pale, di ba? So may problem siya with the oxygen. So that's why we want to learn kung ano yung connection niya.
Yes, ma'am. Thank you po.
So another would be because IDA is already well studied, di ba? So it's well studied. Everybody knows about IDA, and yet based on literature, so it remains to be a big challenge in terms of detection diagnosis. Okay. Now, Sir Jem, you mentioned about the HLA DQ2 and DQ8 genes in one of the
Yes, ma'am.
slides. Can you tell us the significance of these two genes?
Um, this is usually it is found on it is carried by the genes. These genes are found on the patients with celiac disease po. So these genes, yes, yes, ma'am. So
Are these mutant genes or what? Are these normal,
um,
or are they what kind of, is there a genetic alteration that happens with this HLA DQ2 and DQ8 gem?
okay, ma'am. Yes po. Will do po.
I'm also listing down the um, questions left unanswered. Okay, so my last question is, there is a slide about extracellular division. You mentioned about extracellular division. Check on that slide.
Yes, ma'am. I'm going to here, ma'am.
Okay, can you discuss it further? What is going on with the extracellular division before the cell becomes microcytic?
The only idea I read, ma'am, from what I've read, this the reason why in iron deficiency anemia presents as microcytic is because of an extracellular division. Because if they would stop dividing on the usual process or the usual step, it would mean that the produced RBC would have very low hemoglobin concentration. So therefore, in order for each red blood cell to have enough or like sufficient sufficient uh, hemoglobin concentration in the cell, they have to add another mitosis in order for the cell to become a bit smaller, and therefore having an let's see enough enough hemoglobin concentration in their cell to 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 be included in the circulation po, in the blood circulation.
So this is more of a compensatory
Yes, ma'am. Yes,
mechanism,
ma'am.
is it?
Yes. It
So
needs to. Yes, ma'am. It needs to have
okay,
this extra.
so kindly look up for more concrete description of the extracellular division. And then you share with us next week, Sir Jem.
Yes,
Just
ma'am.
so we
Thank you.
know what happens within the cell.
Yes po.
Okay, so bakit siya naging extra, considered extra? So it's like I'm imagining it as a whole pizza, and then you slice into many pieces just so everyone would have a portion of the pepperoni and the cheese. I think I don't know. That's how I imagine it. Okay, but
Yes,
if you could probably make it more clear to us next week.
yes, ma'am. Will do po.
How about the audience? Do you have any other questions? Do you have any local statistics on IDAs or GEM?
Ma'am, the only statistic I found is this. This is based on. Oh my God. Wait. I'll try this. 2019 study by Palanog et al. So the study is entitled Zinc and Iron Nutrition Status in the Philippine Population and Local Soils. So they have the statistics of the prevalence of iron deficiency anemia on the key populations, which includes the infants, pregnant women, lactating women, and elderly males.
Okay, so which leads me to the next question. Please clarify with us, okay, the role of zinc. Does it have anything to do with IDA? If yes, kindly include also in the discussion. Okay, Sir Alex, you're about to ask a question, Sir Alex. Was it you? Sir Alex, are you asking a question?
Yes, hello. Just the correlation between the parasitic infection and the iron deficiency anemia. So if the, if the parasite is removed or the infection is healed, does the iron deficiency anemia, is it completely recovered, or ano? It's just a clarification.
Thank you, Sir Alex, for the question. Actually, in treating iron deficiency anemia due to parasitic infections, or in general, the treatment for iron deficiency anemia is to first treat the underlying cause. So in this case, we have parasitic infection. So we have to remove first what parasites are the causative agents for the iron deficiency anemia. However, if the iron deficiency anemia still persists following the removal or the eradication of the parasitic infection in your body, therefore there is a need to further investigate what are the other possible causes of the iron deficiency, because the parasitic infection is already removed from your body. So maybe there is a possibility of the ulcerations that are still left by the parasite that causes occult blood losses in the patient, or yeah, there would be a need for further testing and investigation as of the cause of the iron deficiency anemia following the parasitic infection removal po.
Thank you, Sir Jem.
Thank you po.
I don't have any more. I do not have any further question. Sir Jem, marami na akong tanong eh. Na siguro for now. Then we will wait for your feedback by next week.
Okay, ma'am. Thank you po.
Thank you, Sir Jem. So do we have another scheduled presenter? Sino yung next?
Good morning po, ma'am. Ako po,
Do you have a nickname?
Gabi po,
What's your
ma'am.
nickname, ma'am?
Gabi po.
Okay, Ma'am Gabi. Yes. Please proceed. You're new to the class? Are you a new student?
Yes po, ma'am.
Okay. Welcome to Advanced Hematology. Okay, so you may proceed with your presentation, Ma'am Gabi.
Okay pa. What? Ay, sorry po. Paano nga po pala to? Present. Ah, ok- okay na po siya po, no? Nakikita naman po.
Yes, ma'am.
Thank you po. Ah, good morning po. Good morning, classmates. Good morning, ma'am. Today, I will discuss about aplastic anemia po. So, aplastic anemia is a rare but serious condition where the bone marrow cannot produce enough new blood cells for the body to work normally. We may call it also as bone marrow failure po. Approximately, we are experiencing 2 to 3 cases per million per year, but having more cases in Asia po. So aplastic anemia usually refers to pancytopenia associated with ineffective hematopoiesis. So pancytopenia means we are having anemia, leukocytopenia, and thrombocytopenia. So clinical features or signs and symptoms of aplastic anemia. So we can categorize it depending on the degree of deficiency po. So we have anemia, leukopenia, thrombocytopenia. So in anemia, we are having the symptoms in anemia in an anemic patient. So we have shortness of breath, pale skin, headache, fatigue. In leukopenia, since the white blood cell is decreased, the patient is prone to infection and bleeding in thrombocytopenia, which is prolonged bleeding, ecchymosis, or bruising, petechiae po. So causes of aplastic anemia, we can categorize it into two or classify it into two: acquired aplastic anemia and inherited or constitutional aplastic anemia. So acquired can be is a result of, mostly it is a result of an autoimmune mediated process. So example of these are radiation po, drugs and toxins, which are benzene, pesticides, carbamazepine, chloramphenicol. Others are triggered by viruses, HIV, EBV, hepatitis, other autoimmune disease, which is SLE, rheumatoid arthritis, and idiopathic causes po, which is 70% of the acquired cases are idiopathic. So we have also inherited aplastic anemia. This results from specific loss of function or mutation. Example of these po are Fanconi's anemia, Dyskeratosis congenita, and Shachman-Diamond syndrome. So here is a table or summarized table of the causes and the pathophysiology and some treatments. So in cytotoxic drug, radiation and benzene, these are the acquired aplastic anemia. They damage the bone marrow directly. So you can have a treatment by having hematopoietic growth factors or stem cell transplantation. In idiopathic and hepatitis, eosinophilic fasciitis, thymoma, these are immune mediated destruction. So we can use immunosuppressive therapy, transplant, and eltrombopag. So in genetic or inherited diseases, we have telomere disease. In telomere disease, which I mentioned earlier, this can be classified as Dyskeratosis congenita because this disease is having a defect in telomere. So since we are having a gene mutation, it is the treatment for this is the stem cell transplantation po. Laboratory evaluation or and diagnosis po. In CBC, we can find here since aplastic anemia is associated with pancytopenia, we are having a decrease in RBC count, white blood cell count, platelet count, reticulocyte count. In white blood cell count, this is specifically in neutrophil po. In myeloid progenitor po. And since we are having anemia, hemoglobin and hematocrit is also decreased. Reticulocyte count is decreased also because our bone marrow is not producing cells. We have ineffective hematopoiesis po. In peripheral blood smear, we can see there cytopenia but no dysplastic features po. And then since aplastic anemia usually is having an MCV of 80 to 100, which is normal, we can see normocytic cells and some macrocytic cells. Another feature of aplastic anemia is the bone marrow po. In bone marrow, we are having hypocellularity. Hematopoietic cells are less than 25% of marrow space, meaning marrow sections will show fatty tissues with inconspicuous fibrosis and some islands of nucleated cells. I can show you a picture of bone marrow experiencing aplastic anemia later po in the following slides. Trilineage hematopoiesis virtually absent with no or few maturing cells. The trilineage po here is the RBC white blood cell, and then the platelet. Since those three are under the myeloid progenitor cell po. So in a bone marrow biopsy, we can have a IHC test, IHC or immunohistochemistry testing of CD34, CD3, and CD20. CD34 is a is seen in stem cell, in hematopoietic stem cell. And CD3, CD20 are used in differentiating B and T lymphoid population. So these three po, IHC testing, can be used in differential testing markers, meaning this CD34, we can differentiate aplastic anemia with other disorders po, like leukemia and MDS. Since in leukemia, we are having blasts, since blasts are mostly CD34 positive cells. In leukemia and in MDS po, this CD34 po is positive. Unlike in aplastic anemia, it is decreased or in normal po. And in CD3 and 20, we can also differentiate aplastic anemia with MDS with this test po. MDS is having positive in these two markers po, while aplastic anemia is negative in this test. So here is a picture po of a bone marrow in high power view showing fatty cells po. So these po are the fatty spaces. It was mentioned here with few nucleated cells, which are plasma cells. So these are the plasma cells po. As I mentioned earlier, the tri-lineage affected by the aplastic anemia are the RBC, neutrophil, and the platelet. Since plasma cells are in the lymphoid lineage po, we can still see a few plasma cells in the bone marrow of an aplastic anemic patient. Another example po. So here is the normal bone marrow and then acute leukemia. So we can see more blast po or other progenitor cells, unlike the aplastic bone marrow. We can see more spaces po. So classification of aplastic anemia. So we can classify this into three: moderate, severe, and very severe. So in moderate, hypocellular bone marrow with at least two of the following po. So neutrophils having 0.5 to 1.5, platelets are also decreased. Reticulocytes are also decreased. Hemoglobin is also decreased, as well as hematocrit. In severe, there is a grading of bone marrow cellularity of less than 25%. Plus, also mentioned earlier, the two of the following. And then the very severe, same with severe classification, but the neutrophils are having a markedly decreased count po, which is less than 0.2. So additional lab studies, we can screen the patient for autoimmune screening to exclude autoimmune etiologies. So these are the anti-nuclear antibody, anti-dsDNA, rheumatoid factor, etc. Liver function tests and viral studies to rule out post-hepatitis aplastic anemia. chromosomal breakage analysis to exclude Fanconi anemia, and TERC and TERT mutation analysis with consideration of telomere length measurement po to investigate this keratosis congenita. Ma'am, that's all po.
Do you have any question, audience? Can you define the term, Ma'am Gabby, can you define the term dysplastic?
Plastic po. Ma'am, yung a po,
Dysplastic.
meaning no po. This,
No,
sorry
ma'am,
po, this
dysplastic.
po ba?
Dysplastic.
This
I think you have a
plastic po.
slide. Yeah, DYS dysplastic.
This plastic po, ma'am, parang ano po, abnormal production po, ma'am.
Can you provide a more concrete definition, Ma'am Gabby?
For a while po, ma'am.
You look it up.
Yes po, ma'am.
Okay, so based on the presentation, so the aplasia, okay, so aplastic anemia affects the trilineage. Okay, so it was emphasized. So you have the cells that arise from the myeloid progenitor. So you have the red blood cell, and then you have the granulocytes.
Yes po.
Specifically, so you mentioned about the neutrophils, ma'am.
Yes po,
And
ma'am.
then the other one is platelets.
Yes po.
So, then you also mentioned about a telomere defect in this keratosis congenita,
Yes
right?
po. Yes
So
po.
is it under the hereditary or the acquired? Can you show the slide?
I see it, ma'am. This one po, ma'am. Nakikita naman po, ma'am. Viewable naman po.
What slide is it?
Ito
Slide
po
number
sorry, ma'am. This one po, ma'am.
under inherited aplastic anemia. Okay, so we are interested in this particular condition. So how does the telomere defect lead to aplastic?
Telomeres, ma'am, are essential po in cell mitosis po. So as the cell is younger po, the telomeres are long po. And as time goes by, the telomere po should be short. So that is the signal of the cell to die. Sure. Ayun po. In telomere defect, ma'am, the telomere length po is not long. It's already short po. So the cells are signaled to the term, ma'am, is senescence po. So eventually, since the cell is old, it eventually dies po, ma'am.
Maybe you can share with us next week
Sige po, ma'am.
a picture about cell division,
Okay po.
showing the portion of the role of the what happens to the telomeres.
Okay po.
That is there a particular during migration? So isn't it after the chromatin material moves about, and then you have the telomeres. So just show to us next week, Ma'am Gabi,
Yes po.
so that we will understand if there is a defect in the telomere, what would be why would aplastic anemia result. Okay, so and also the term dyskeratosis congenita. So probably some more description
Yes,
about
ma'am.
this particular condition. Okay.
Noted, ma'am.
Okay, so can you discuss the role of the clusters of differentiation 34, CD34, CD3, CD20? So you mentioned that these markers are being used to differentiate aplastic anemia with leukemia and myelodysplastic syndrome, right?
Yes po.
So kindly clarify the role or the function of these different CDs. Okay. So they are markers for what particular receptors? And then
Sorry, ma'am. Clarify
what
ko
do you
lang
mean
po.
by ayan, so lahat yun, ma'am. So kindly look up
Okay
specific significance of
Okay.
CD34, CD3, and CD20. So we know they are markers, and
Yes po.
we know that they are being used to differentiate aplastic anemia with leukemia and MDS. But by way of function role, okay, so can you clarify on that next week, Ma'am Gabi?
Noted,
And then another would be you have a slide showing bone marrow cellularity depending on the severity of aplastic anemia. So you have moderate, and then you have severe, and then very severe. Can
Okay.
you show it to us?
Yes po. Is this one, ma'am, or this one po?
Yan. Okay.
Ito.
The tabulation. Can you clarify what is meant by bone marrow cellularity of less than 25%?
Ma'am, in next week's meeting po ba magpapakita po ako, or today po ako
Yes, pwede. If you don't, can you answer
Okay
it
po.
right away today? So if not, you can hold the class next week. Okay,
Okay
because
po.
there must be some reference standard. So
Okay po.
there should be reference values, okay,
Okay po.
as basis for the bone marrow cellularity. So, meaning to say, if you have a bone marrow cellularity of less than 25%, you will fall under either of the three categories for aplastic anemia. So, kindly share with the class the standard reference ranges for this bone marrow cellularity. Okay, and what are the expected distribution of cells? Okay, for bone marrow cellularity, normal bone marrow versus aplastic bone marrow. Okay. Next week na, Ma'am Gabi.
Yes
And then
po.
also, can you also discuss the ME ratio?
Okay po.
Are you familiar with the ME of the
Yes.
computations being done for bone marrow analysis?
Okay po. Sige.
So, what is the ME ratio in a patient with aplastic anemia? Another one would be the drug induced. Okay, so you have another slide showing the causes of aplastic anemia. So there's a column about the use of phenycols. So yeah, so chloramphenicol, and then you have the treatment for epilepsy, so carbamazepine, and then some chemicals. Okay, so and then in the next slide, you have another picture showing that drug-induced or chemical-induced plastic anemia. Yeah, that's one. That's the one. So the for the pathophysiology, so uh, chemical and physical damage to the bone marrow. It.
Yes.
So can you give more information about the damage, the particular damage gives to the bone marrow?
Noted, ma'am.
So search mo siya.
Okay po.
Okay, so what exactly happened? The other information here are rather very easy to understand. Yes, sir, Peter.
Ma'am, I have a question for Ma'am Gabby. Gabby, since aplastic anemia affects the bone marrow, and as you know, the bone marrow is divided into the yellow marrow and the red marrow. Which part of the bone marrow is affected in aplastic anemia?
The red part, the red marrow, sir. Eventually, since the red marrow is decreased po, eventually the bone marrow compensates the loss po. So, in aplastic anemia, we are having more yellow marrow compared to the red marrow, sir.
Okay, ma'am.
Thank you po.
Okay, so any age-related incidents or report about the plastic anemia? So do you have any census probably or statistics?
I can give it to you, ma'am, by next week, but in my in that journal I read po, ma'am, more on young po, on the young bracket, and then some old adults po. But I can give you more details on by next week. Sorry, ma'am.
Okay, no problem. Okay, so any more clarifications? We will expect that you will show to us the breakdown of the bone marrow because the bone marrow analysis also includes there is a differential count also
Yes po.
for bone marrow. Oh, so it's like a CBC, but
Yes po.
the specimen is the bone marrow. Okay, so we want to see the distribution of the cells in a normocellular versus the hypocellular aplastic bone marrow. Okay, Ma'am Gabby. Sir Pax, you're raising your hand. Are you asking a question? Okay.
Yes, ma'am. Ma'am Gabriela, my question is, since aplastic anemia is a life-threatening condition, is it a reversible condition? And the second question would be, is there a gold standard in diagnosing this condition?
Thank you po, sir. Sir, sorry. With regards to the gold standard po, sir, In what I have read po, sir, in diagnosing aplastic anemia, it's like an exclusion of diagnosis, sir. Parang ano siya? Anong tawag to? Elimination po, sir. So, having certain tests when something is not aligned to aplastic, the physician will order another test po. And the first question po. Sorry, ano po ulit yung first question?
Is it a reversible condition?
In what I have read din po, sir, it depends on the cause of the disease po. So in case of the drug-dependent, in drug-induced aplastic anemia, we can lessen the exposure po. Opo. Sorry, sir. I will get back to you on that.
Okay, so how about the rest of the class? Do you have any other clarificatory question to Ma'am Gabi?
Hello, ma'am.
Yes,
Sir
sir.
Alex po.
Sir Alex, okay.
Just another question regarding telomeres, because telomere length is correlated with aplastic anemia. So is there a measure in length that can help with the diagnosis or prognosis? Is there a measure or a way to measure the length of telomeres that can correlate it with the diagnosis or prognosis of aplastic anemia?
Thank you for that question, sir. But I think I will get back to you on that next week. Sorry
Thank you,
po.
ma'am. Thank you. No problem.
Ma'am Gabi, include the laboratory analysis for the telomere defect. Okay, so there is a specific test, okay, that will show the defect in the telomere. Okay, so include it also in your by next week.
Noted, ma'am.
More questions? So please make sure all presenters please share your material with the rest of the class, and don't forget to send it to me as well for proper grading. Okay. All of the students who participated in the discussion, so I have my own notebook here, so I jot down your names for proper credits. Okay, and also I usually list the questions that are being thrown at you. Okay, and we are expecting answers to the questions. Okay? So that you will have a credit as well. No more questions? Going once, going twice? Okay, so if you notice, most of the presentations already include molecular, okay, list of the disorders. Okay, so before, not much are being done, okay, to emphasize the molecular basis. So, but now if you look at the presentations, okay, so the mutations, okay, the defect genetic analysis, okay, so are also being emphasized. Right, so if there are no more questions, I will be dismissing you earlier. I will see you next week for our next session. Okay, so I appreciate your active participation in the discussions.
Thank you, ma'am.
Okay, so yeah, so class dismissed, and I'll see you next week.
Thank you.
Thank
po.
you.
Thank you, ma'am.